Traps number 2. Renal, acid-base, and electrolytes. The chapter where 2 diseases share every symptom and differ by 1 number. 50 questions, each built on the detail that separates them. Find the discriminator and the question collapses. Which is the most likely cause of his acute kidney injury? A 72-year-old man is admitted with vomiting and poor intake. Creatinine has risen from 1.0 to 2.6 milligrams per deciliter. Urine sodium is 12 milliequivalents per liter. Fractional excretion of sodium is 0.4%, and the Buntu creatinine ratio is 28. Urine microscopy shows hyaline cast only. Read the command, the cause of the acute kidney injury. Prerenal injury and acute tubular necrosis look identical on the creatinine alone. The urine tells you whether the tubules are still working. The discriminator is whether the tubule is alive. In prerenal azotemia, the kidney is underperfused but structurally normal, so it does exactly what a healthy kidney should. It avidly reabsorbs sodium and water. That produces a low urine sodium, a fractional excretion of sodium, below 1% concentrated urine, and a Buntu creatinine ratio above 20, because urea is reabsorbed along with the water. In ACU tubular necrosis, the tubular cells are dead and cannot reabsorb anything. The fractional excretion rises above 2%, the urine is isosthenuric, and muddy brown granular casts appear. None of that is present here, so choice A is excluded. The correct answer is B. The relationship between the two is a continuum rather than a dichotomy, which is why the distinction is urgent. Sustained hypoperfusion eventually kills the tubular cells and converts prerenal azotemia into ischemic acute tubular necrosis. Restoring perfusion early reverses the first entirely. Choice C will show white cell casts and often eosinophils with a drug exposure, and choice D will show hydronephrosis on imaging. Neither produces this pattern of extreme sodium avidity. If you see a fractional excretion of sodium below 1% with a high BUN to creatinine ratio, leads to think prerenal. Which syndrome does this represent, and what defines it? A 6-year-old boy has periorbital edema and frothy urine. Urinalysis shows 4+ protein and no blood. Serum albumin is 1.8 grams per deciliter, cholesterol is elevated, and 24-hour urine protein is 4.6 G. Blood pressure and creatinine are normal. Read the command. Which syndrome and what defines it? Nephrotic and nephritic are the two halves of glomerular disease, and confusing them misdirects every subsequent step. Nephrotic syndrome is a disorder of the filtration, BAR. Podocyte injury lets protein pour through, giving proteinuria above 3.5 G per day, hypoalbuminemia, edema, hyperlipidemia, and a bland urine sediment. Nephritic syndrome is a disorder of eye inflammation. Glomerular capillaries are attacked, so red cells escape, producing hematuria with RED cell casts, hypertension, oliguria, and a rising creatinine, with proteinuria that is typically subnephrotic. This patient had the barrier picture without a trace of inflammation, so choices B, C, and E are excluded by the absence of blood, hypertension, and azotemia. The correct answer is A. Choice D is wrong on a specific and testable point. The nephrotic sediment is bland, and its most characteristic finding is oval fat bodies with Maltese crosses under polarized light, not casts of cells. Two complications follow directly from what is lost in the urine and are frequently examined. Losing antithrombin 3 creates a hypercoagulable state with a particular risk of renal vein thrombosis, and losing immunoglobulins predisposes to infection with encapsulated organisms. If you see heavy proteinuria with a bland sediment, leads to think nephrotic and ask what else was lost. Which pairing is correct? 2 young men present with hematuria after an upper respiratory infection. Patient 1 develops visible hematuria 2 days after the sore throat with normal complement. Patient 2 develops cola-colored urine, edema, and hypertension 3 weeks after with a lousy 3. Read the command. Which pairing is correct? Both follow a sore throat and both cause hematuria. The interval and the complement level separate them completely. IgA. Nephropathy produces hematuria, symphory, Diuretic within 1 to 3 days of the mucosal infection because circulating IgA is already present and is deposited in the mesangium immediately. Complement C3 is normal. Post. Streptococcal glomerulonephritis requires time for antibody production and immune complex formation, so it appears 1 to 3 weeks after the infection, and because complexes activate the complement cascade, C3 is low. The interval alone distinguishes them, and the complement confirms it, which makes choice B an exact inversion. The correct answer is C. The prognosis diverges as sharply as the timing. Post-streptococcal glomerulonephritis in a child usually resolves completely, whereas IEA nephropathy is a chronic, recurrent disease that progresses to end-stage renal disease in a substantial minority. IgA nephropathy also has a systemic sibling worth recognizing, HENoC. C9 purpura deposits the same IgA in skin, joints, and gut, presenting with a palpable purpuric rash on the buttocks and legs, arthralgia, and abdominal pain. If you see hematuria within days of a sore throat with normal complement leads to think IgA nephropathy. Which statement about these two mechanisms is correct? A patient with chronic kidney disease is given ibuprofen. Renal blood flow falls and glomerular filtration rate drops sharply. In a different patient with bilateral renal artery stenosis, an ACE inhibitor produces a similar fall in filtration rate. Read the comment. Which mechanism statement is correct? Two drugs drop the filtration rate, but they act on opposite ends of the glomerulus. Glomerular filtration depends on the pressure gradient across the capillary tuft, and two hormones maintain it under stress. Prostaglandins dilate the afferent arteriole, keeping flow in. NSAIDs block prostaglandin synthesis, so the afferent arteriole constrictus and inflow falls. Angiotensin II constrictus the efferent arteriole, holding pressure inside the tuft. ACE inhibitors remove that constriction, the efferent arteriole dilates, and glomerular pressure falls. Different arterioles, opposite directions, same net drop in filtration, which is why choices A, B, and C each misassign at least one vessel. The correct answer is D. The clinical consequences follow directly and are examined often. Because bilateral renal artery stenosis makes the kidney entirely dependent on efferent constriction to sustain filtration, an ACE inhibitor can precipitate acute kidney injury and is contraindicated there. Yet the same efferent dilation is protective over years in diabetic nephropathy. Because lowering intraglomerular pressure reduces hyperfiltration injury, the acute cost buys long-term preservation, and a modest rise in creatinine after starting the drug is expected rather than alarming. If you see, a drug-induced fall in filtration rate leads to identify which arteriole the drug controls. Which statement explains this sequence? A 17-year-old with type 1 diabetes has diabetic ketoacidosis. Serum potassium on arrival is 5.6 milliequivalents per liter. 2 hours after starting insulin and fluids, potassium falls to 2.9 milliequivalents per liter, and he develops ventricular ectopy. Read the command. What explains the sequence? The arrival potassium is one of the most dangerous numbers in medicine because it says the opposite of what it means. In diabetic ketoacidosis, insulin deficiency and acidosis drive potassium OUT of cells and into the serum, while the osmotic diuresis simultaneously flushes enormous quantities of potassium out in the urine. The result is a normal or HIEH serum potassium sitting on top of a severely depleted total body store. When insulin is given, it drives potassium back ion 2 cells within minutes, and the true deficit is unmasked as a precipitous fall, with the arrhythmia risk seen here. Choice C reads the serum number as if it reflected total body content, which is exactly the error. The correct answer is E. The management rule that follows is absolute and frequently tested. If the presenting potassium is below 3.3, potassium replacement must be given before insulin is started because insulin in that setting can precipitate fatal arrhythmia. Potassium is repleted throughout the resuscitation regardless with hourly monitoring. Choices. A and B name mechanisms that do not fit. Hemolysis would not resolve with treatment, and insulin promotes cellular uptake rather than renal wasting. If you see a normal or high potassium in ketoacidosis, leads to assume the total body store is empty. What is the first drug that should be given? A patient with chronic kidney disease has a potassium of 7.4 milliequivalents per liter. The ECG shows peak T waves and a widening QRS. Read the command, the first drug. Several agents treat hyperkalemia, and they do 3 different jobs. Only one of them protects the heart immediately. Hyperkalemia kills by depolarizing the resting membrane. Sitting closer to threshold, voltage-gated sodium channels inactivate, conduction fails, and the QRS widens toward a sine wave and asystole. Calcium does not lower potassium at all. It raises the threshold potential, restoring the gap between resting and threshold and stabilizing the myocardium within minutes. That is why it goes first whenever the ECG is abnormal. Everything else takes longer. Insulin with dextrose and albuterol shift potassium into cells over 15 to 30 minutes, and only dialysis, loop diuretics or binders such as choice C actually remove it from the body. The correct answer is D. Holding the 3 categories separate prevents the most common error, which is treating a dangerous ECG with a slow-acting agent. Choices A, B, and E are all correct treatments and all belong in the regimen, but each takes tens of minutes to act while the patient is at immediate risk of arrhythmia. One caution completes the picture. In patients on digoxin, calcium is given cautiously, since hypercalcemia potentiates digoxin toxicity. If you see hyperkalemia with ECG changes leads to give calcium first, then shift, then remove. Which disorder is present? A 33-year-old woman has recurrent calcium phosphate kidney stones. Serum potassium is 3.1 milliequivalents per liter, and bicarbonate is 15 milliequivalents per liter with a normal anion gap. Despite the acidemia, urine pH remains 6.4. Read the command, which disorder? 3. Renal tubular acidosis looks similar on the bicarbonate alone. The urine pH and the potassium together identify each one. An acidemic patient should acidify the urine below 5.5. Failure to do so means the distal tubule cannot secrete hydrogen ion, TYP1, distal renal tubular acidosis. 2 consequences follow and both appear here. Potassium is lost in place of the hydrogen that cannot be secreted, giving hypokalemia, and the persistently alkaline urine precipitates calcium phosphated stones with nephrocalcinosis. TYPE2, proximal disease, fails to reabsorb bicarbonate, but once the serum bicarbonate falls below the reduced threshold, the distal tubule still acidifies normally, so urine pH does fall below 5.5. Choice A. Wrong. The correct answer is C. Type 4 is the one that stands apart and is easiest to spot, which makes choice B testable. It results from hypoaldosteronism, most often the hyporenemic hypoaldosteronism of diabetic nephropathy, and it is the only renal tubular acidosis with hyperkalemia. Choice D also produces a normal gap acidosis, but the kidney is healthy and acidifies the urine appropriately. The urinary anion gap distinguishes them, being negative in diarrhea and positive in renal tubular acidosis. If you see a normal gap acidosis with urine, pH above 5.5 leads to think type 1 and check the potassium, which is the most likely diagnosis. A 44-year-old man passes 9L of dilute urine daily. Urine osmolality is 88 milliosmoles per kilogram. After administration of desmopressin, urine osmolality rises to 620 milliosmoles per kilogram. Read the command, the most likely diagnosis. 2 forms of diabetes. Insipidus produce identical dilute polyuria. One test tells them apart in a single step. Desmopressin is a synthetic antidiuretic hormone analog. If the kidney concentrates the urine in response, the collecting duct receptors and aquaporins are intact, and the problem is that the pituitary was not producing hormone. Central diabetes insipidus from trauma, surgery, tumor, or autoimmune destruction. If the urine does not concentrate, the hormone is present, but the kidney cannot respond. Nephrogenic diabetes insipidus from lithium, hypercalcemia, hypokalemia, or an inherited receptor defect. A rise from 88 to 6220 is a clear response, which excludes choice A. The correct answer is E. Primary polydipsia is the third member of this differential and is separated before desmopressin is ever given, which is why choice B fails here. Excessive drinking produces a low, normal serum sodium because the water load is exogenous, whereas both forms of diabetes insipidus produce a Higgs normal or frankly elevated sodium as water is lost. Our water deprivation test makes the same distinction. Choice C would show an elevated rather than a very low urine osmolality, since glucose is an osmotic solute. If you see dilute polyuria leads to give desmopressin and watch whether the kidney can hear the signal. Which is the most likely cause? A 68-year-old man with small cell lung carcinoma has a serum sodium of 118 milliequivalents per liter. He is clinically euvolemic with no edema and no orthostasis. Urine osmolality is 540 milliosmoles per kilogram, and urine sodium is 62 milliequivalents per liter. Thyroid and adrenal function are normal. Read the command, the cause of the hyponatremia. Volume status is the first branch point in every hyponatremia, and this patient is explicitly euvolemic. Hyponatremia is classified by volume status. H hypovolemic forms show orthostasis and a low urine sodium as the kidney conserves. H hypovolemic forms show edema from heart failure, cirrhosis, or nephrotic syndrome. Euvolemic hyponatremia with concentrated urine and a urine sodium above 40 is the signature of SIADH. Antidiuretic hormone is being secreted without an osmotic or volume stimulus, water is retained, and the kidney continues excreting sodium normally. Small cell carcinoma is the classic ectopic source. Choices A and C are excluded by the stated euvolemia. The correct answer is B. Choice D fails on the urine osmolality, which is the most efficient discriminator in the group. In primary polydipsia, the kidney responds appropriately by producing maximally dilute urine with an osmolality below 100. Choice E is genuinely difficult to separate from SIADH and differs chiefly by volume depletion. The distinction matters because cerebral salt wasting is treated with salt and volume, whereas fluid restriction in SIADH would worsen it. If you see euvolemic hyponatremia with concentrated urine leads to think SIADH and look for a lung or brain cause. Which complication has occurred? The serum sodium of 180 milliequivalents per liter in a chronically hyponatremic patient is corrected to 102 milliequivalents per liter over 14 hours. 2 days later, he develops dysarthria, quadriparesis, and impaired consciousness with an intact level of alertness fluctuating toward a locked-in state. Read the command. Which complication occurred? The number was normalized, and that is exactly the problem. The rate of correction matters more than the destination. In chronic hyponatremia, brain cells extrude organic osmolytes over days to avoid swelling. Once adapted, they cannot reaccumulate those osmolytes quickly. Raising serum sodium too fast makes the extracellular space suddenly hypertonic relative to the adapted cell. Water leaves the neuron and osmotic. Demyelination follows classically in the central pons, producing dysarthria, dysphagia, and quadriparesis that appear 1 to several days after the correction, when the sodium looks reassuringly normal. The safe limit is roughly 8 milliequivalents per liter in 24 hours. This patient received 3 times that. The correct answer is A. The symmetry is what makes this examinable in both directions, so choice B is not merely wrong but the mirror of the truth, correcting too slowly and inacutely. Hyponatremic, seizing patient risks cerebral edema and herniation, and there hypertonic saline is given deliberately. The chronicity of the hyponatremia decides which risk dominates. Choices C, D, and E produce different syndromes with different time courses and no relation to the sodium trajectory. If you see a delayed Pontine syndrome after correcting sodium leads to think osmotic demyelination. Which is the complete interpretation? A patient has an arterial pH of 728, PaCO2 of 26 millimeters of mercury, and bicarbonate of 12 milliequivalents per liter. Sodium is 140, chloride is 100. Winter formula predicts an expected PaCO2 of 26 millimeters of mercury. Read the command, the complete interpretation. 3 steps are required. Name the primary disorder, calculate the anion gap, and check whether compensation is appropriate. Work it in order. The pH is acidic and the bicarbonate is low, so the primary disorder is a metabolic acidosis. The anion gap is sodium minus chloride and bicarbonate, 140 minus 100 minus 12, which is 28, clearly elevated, so it is an anion gap acidosis. Finally, Winter formula predicts the PaCO2 the lung should achieve 1.5 times the bicarbonate plus 8, which gives 26. The measured PaCO2 is exactly 26, so compensation is APP appropriate and no second primary disorder is present. Choice A would require the measured CO2 to be lower than predicted. The correct answer is C. The reason compensation is checked rather than assumed is that it converts a two-line gas into a diagnosis of mixed disease, which changes the differential entirely. Choice B fails at step 2, since a gap of 28 is far from normal, and a normal gap acidosis would point toward diarrhea or renal tubular acidosis rather than toward the gap, producing causes remembered as MUD piles. Choice D inverts, which value is primary. Compensation never drives the pH past neutral, so an acidemic pH cannot arise from a primary respiratory alkalosis. If you see an acid-base problem leads to primary disorder, then anion gap, then compensation, always in that order, which is the most likely ingestion. A 41-year-old man is brought in confused after drinking from an unlabeled container in a garage. pH is 7.6 with an anion gap of 26. Measured serum osmolality is 342 milliosmoles per kilogram, while calculated osmolality is 302. Urine microscopy shows envelope-shaped crystals, and he has flank pain and oliguria. Read the command, the ingestion. An osmolar gap with an anion gap acidosis names the class of poison. The target organ names the specific one. An OS-molar gap, measured minus calculated osmolality above roughly 10, means an unmeasured small solute is circulating, and combined with an anion gap acidosis, this points to a toxic alcohol. The two are then separated by which organ they injure. HY-lean glycol is metabolized to oxalate, which precipitates as calcium. Oxalate crystals, the envelope-shaped crystals described, producing acute kidney injury with flank pain, oliguria, and hyperkalemia. Methanol is metabolized to formic acid, which attacks the retina and optic nerve, producing visual blurring and a snowstorm appearance rather than renal failure. Choice wrong. The correct answer is E. Isopropyl alcohol is the instructive exception in the group and makes choice B distinguishable. It is metabolized to acetone rather than to an organic acid, so it produces an osmolar gap and ketosis, without an anion gap acidosis. Treatment for the two dangerous alcohols is to block their metabolism with foamy-soluble, an alcohol dehydrogenase inhibitor, since the parent compounds are relatively harmless and the metabolites do the damage, with hemodialysis for severe poisoning. If you see an osmolar gap with an anion gap acidosis leads to decide between the eye and the kidney, which is the most likely diagnosis. A 9-year-old boy develops bloody diarrhea, then oliguria and pallor. Hemoglobin is 7.4 grams per deciliter with schistocytes. Platelets are 38,000 or micro-L, and creatinine is 3.2 milligrams per deciliter. Neurological examination is normal and there is no fever. Stool culture grows Escherichia coli, O57H7. Read the command, the most likely diagnosis. 2 thrombotic microangiopathies share a triad. The organ they favor and the preceding illness separate them. Both hemolytic uremic syndrome and thrombotic thrombocytopenic purpura produce microangiopathic hemolysis with schistocytes and consumption of platelets and microthrombi, Hemolytic uremic syndrome follows Shiga toxin producing E. coli 057H7, occurs in children after bloody diarrhea, and the toxin has a particular affinity for renal endothelium. So renal failure dominates and neurological SIG affinity for renal endothelium. So renal failure dominates and neurological signs are usually absent. Thrombotic. Thrombocytopenic purpura arises from deficient Adams 13, occurs in adults, and adds fever and neurological signs to the same triad. Choice are wrong. The correct answer is D. Two management points separate them decisively and are examined. Hemolytic uremic syndrome is treated suppuratively, and antibiotics are avoided because bacterial lysis releases more Shiga toxin and may worsen the illness. Thrombotic thrombocytopenic purpura is a hematologic emergency treated with plasma e-exchange. Choice C would show a prolonged prothrombin time with low fibrinogen and elevated D-dimer, whereas coagulation studies are characteristically normal in both microangiopathies, a discriminator worth remembering on its own. If you see schistocytes with renal failure after bloody diarrhea in a child leads to think hemolytic uremic syndrome. Which lesion is described? A 58-year-old man with 15 years of type 2 diabetes has 3.8 g of proteinuria daily and a creatinine of 2.1 milligrams per deciliter. Renal biopsy shows thickened glomerular basement membranes and nodular eosinophilic masses within the mesangium. Read the command. Which lesion is described? Nodular glomerular lesions are few, and each carries a specific name that appears verbatim in exam stems. Chronic hyperglycemia non-enzymatically glycosylates proteins in the glomerular basement membrane, causing progressive thickening and mesangial expansion. Over years, the mesangial matrix coalesces into rounded acellular eosinophilic nodules, Kimmelstiel-Wilson nodules, the histologic hallmark of DIAB-ET nephropathy. The clinical arc that precedes them is testable in its own right: hyperfiltration first, then microalbuminuria, then overt proteinuria, then declining filtration. Choices B, C, and D name lesions of entirely different diseases. The correct answer is A. The therapeutic link back to glomerular hemodynamics is what makes this more than a naming exercise, because efferent constriction drives the hyperfiltration that injures the glomerulus. An AC inhibitor or angiotensin receptor blocker dilates that arteriole, lowers intraglomerular pressure, and slows progression, which is why screening for microalbuminuria matters, since intervention at that stage alters the trajectory. Choice E describes minimal change disease, which shows a normal glomerulus on light microscopy. If you see nodular mesangial masses in a long-standing diabetic leads to think Kimmelstiel-Wilson. Which pairing is correct? Two patients have glomerulonephritis. Patient 1's immunofluorescence shows smooth linear deposition of IgG along the basement membrane. He also has hemoptysis. Patient 2 shows coarse granular deposits of IgG and C3. Read the command. Which pairing is correct? Immunofluorescence gives 3 patterns, and each maps to one mechanism of glomerular injury. The pattern reveals how the antibody arrived. Linear staining means antibody is bound directly and uniformly to a fixed antigen in the basement membrane itself. Anti-GBM disease, targeting the alpha-3 chain of type 4 collagen. Because that same antigen exists in the alveolar basement membrane, the lung is attacked too, giving the pulmonary renal syndrome with hemoptysis known as good pasture. Granular or lumpy bumpy staining means preformed immune complexes have deposited irregularly. Post-streptococcal disease, lupus, membranous nephropathy. Choice C reverses the two, and choice A collapses them. The correct answer is B. The third pattern completes the framework and is what choice D misapplies, PAUCI. Immune disease shows little or no immunofluorescence despite aggressive glomerular destruction, and it belongs to the ANCA-associated vasculitides. All 3 patterns can produce rapidly progressive glomerulonephritis with crescents in Bowman's base, which is precisely why the immunofluorescence is required. The light microscopy looks similar while the treatment and associations differ completely. If you see Linear immunofluorescence with hemoptysis leads to think anti-GBM disease. What is the most appropriate action? A 63-year-old man with end-stage renal disease on hemodialysis tells his nephrologist he wishes to stop dialysis. He understands he will die within weeks, explains his reasoning consistently, and has no depression on formal assessment. His daughter demands that treatment continue. Read the command. The most appropriate action. Stopping a life-sustaining treatment feels different from refusing to start one, but ethically and legally it is not. A patient with intact decision. Making capacity may refuse any treatment, including one that is sustaining life, and withdrawing a treatment already started carries the same ethical weight as never starting it. Capacity requires that the patient understand the situation, appreciate the consequences, reason consistently, and communicate a choice. All four are documented here. Autonomy therefore governs, and a competent patient's decision cannot be overridden by a family member, however sincere. Choice B would substitute a surrogate for a patient who does not need one, since surrogates act only when capacity is lost. The correct answer is C. The depression screen is not a formality and is the detail that makes this question answerable rather than reflexive. Untreated depression can distort the appreciation component of capacity, and the refusal driven by treatable illness deserves treatment first. It was explicitly excluded here, which removes the basis for choice D. A wish to stop a burdensome treatment and allow an underlying disease to take its course is not suicidal intent. Choices A and E delay honoring a valid refusal, which itself constitutes unconsented treatment. If you see a capacitated patient refusing life-sustaining treatment leads to honor it after screening for depression. Which statement best explains this difference? In the nephron, sodium is reabsorbed at several sites. A drug acting at the thick ascending limb produces a much greater natriuresis than one acting at the distal convoluted tubule. Read the command, why one site yields more natriuresis. Diuretic potency follows directly from how much sodium passes each segment. Sodium reabsorption is distributed unevenly along the nephron. The proximal tubule handles about 65%, the thick ascending limb about 25% through the sodium-potassium 2-chloride cotransporter, the distal convoluted tubule about 5% through the sodium chloride cotransporter, and the collecting duct a few percent under aldosterone control. Blocking a segment can only excrete the sodium that reaches it, so a loop diuretic acting on 25% is intrinsically far more potent than a thiazide acting on 5%. That is the whole explanation, and choices A and E contradict the existence of the transporters that thiazides target. The correct answer is B. The calcium handling of the two classes diverges and is a favorite second-order question worth attaching here. Loop diuretics abolish the lumen-positive potential that drives paracellular calcium reabsorption, so calcium is lost. Useful in hypercalcemia. THIazides enhance distal calcium reabsorption, so calcium is retained. Useful in calcium stone prevention and in osteoporosis. Choice D confuses classes, since carbonic anhydrase inhibition is the mechanism of acetazolamide in the proximal tubule. If you see, a diuretic potency question leads to ask what fraction of filtered sodium the segment handles. Which pairing is correct? 3 adults with nephrotic syndrome undergo biopsy. Patient 1, normal light microscopy, foot process effacement on electron microscopy. Patient 2, segmental sclerosis in some glomeruli associated with HIV. Patient 3, diffusely thickened basement membrane with subepithelial spikes and anti-PLA2R antibodies. Read the command, which pairing is correct. 3 nephrotic patterns, each with 1 histologic signature and 1 clinical association. Minimal. Cheney's disease is normal on light microscopy. Its only finding is foot process effacement on electron microscopy. And it is the commonest nephrotic syndrome in children, responding briskly to steroids. Focal segmental glomerule. Sclerosis affects some glomeruli and only part of each, and it is associated with HIV, heroin use, obesity, and sickle cell disease. It is the commonest cause in adults of African descent. Membranous nephropathy thickens the basement membrane with subepithelial deposits producing a spike in dome appearance, and anti-PLA2R antibodies identify the primary form. The three descriptions map in order. Which choices A, B, and D each scramble? The correct answer is E. The secondary associations of membranous nephropathy are what make it more than a histologic label. It can be the presenting manifestation of a solid tumor, hepatitis B, systemic lupus erythematosus, or drug exposure, so a new diagnosis in an older adult prompts a search for malignancy. Membranous nephropathy also carries the highest risk of renal vein thrombosis among the nephrotic syndromes, a complication that should be suspected with sudden flank pain and worsening proteinuria. If you see, a nephrotic biopsy leads to read the light microscopy first, then the electron microscopy, then the serology, which is the most likely diagnosis. A 55-year-old woman develops a creatinine rise to 2.8 milligrams per deciliter 10 days after starting a proton pump inhibitor. She has a maculopapular rash and a low-grade fever. Eosinophils are 8% of the differential, and urinalysis shows white cells with white cell cast and no bacteria. Read the command. The most likely diagnosis, sterile pyuria, with a drug exposure and systemic allergic features, is one specific lesion. Acute interstitial nephritis is a hypersensitivity reaction in the renal interstitium, typically appearing days to weeks after exposure to a culprit drug. Classically, penicillins and cephalosporins, NSAIDs, proton pump inhibitors, sulfonamides, and rifampin. The triad of rash, fever, and eosinophilia is the classic presentation, though all three are present in a minority. The urinary sediment shows WHIT, cells and white cell cast with sterile culture. The absence of bacteria is what excludes pyelonephritis, choice B, wrong. Treatment is stopping the drug with steroids in severe cases. The correct answer is D. The casts are the most efficient way to localize renal injury and worth committing as a set, since each type points to a different compartment. Red CL casts mean glomerulonephritis, white CL casts mean interstitial inflammation or pyelonephritis. Muddy brown granular casts mean acute tubular necrosis, and fatty casts with Maltese crosses mean nephrotic syndrome. Choice C would show red cell cast and a far more aggressive creatinine trajectory, and choices A and E lack any inflammatory sediment. If you see eosinophilia and white cell cast after a new drug leads to think acute interstitial nephritis. Which stone composition is most likely? A 48-year-old woman has recurrent urinary infections with Proteus mirabilis. Imaging shows a large branching stone filling the renal pelvis and calyces. Urine pH is persistently 8.1. Read the command, the stone composition. Urinary pH and the organism together identify the stone before any analysis returns. Proteus, Klebsiella, and other ureas. Producing organisms split urea into ammonia, which alkalinizes the urine. In that alkaline environment, magnesium ammonium phosphate precipitates as struvite, forming the large branching staghorn calculi that fill the renal pelvis. The stone then harbors bacteria within it, so infection and stone perpetuate each other, and the calculus must be removed entirely to break the cycle. Uric acid stones form under the opposite condition. AC urine below 5.5, and they are radiolucent, so choice C is excluded by the pH alone. The correct answer is A. Calcium oxalate remains the commonest stone overall, and is the default answer when no pH or organism is specified, which is why choice B is the most tempting distractor. But its formation is not pH driven, and it does not produce staghorns. The therapeutic logic follows the chemistry. Uric acid stones are dissolved by alkalinizing the urine, cysteine stones by alkalinization and hydration, and recurrent calcium stones are reduced by TH isidis, which enhance distal calcium reabsorption and lower urinary calcium. If you see a staghorn calculus with alkaline urine leads to think struvite and a urease producing organism. Which pairing is correct? Two young adults have hypokalemic metabolic alkalosis with normal blood pressure and elevated renin. Patient 1 has hypercalciuria and a defect resembling chronic loop diuretic use. Patient 2 has hypocalciuria, hypomagnesemia, and a defect resembling chronic thiazide use. Read the command. Which pairing is correct? 2 inherited tubulopathies mimic 2 diuretics, and the calcium in the urine tells you which segment is affected. Bartter syndrome is a defect of the sodium-potassium 2-chloride cotransporter in the thick ascending limb, the loop diuretic target, so it reproduces loop physiology including hypocalciuria, and it presents earlier and more severely. Gitelman syndrome is a defect of the sodium chloride cotransporter in the distal convoluted tubule, the thiazide target, so it reproduces thiazide physiology including hypocalciuria, and it characteristically adds hypomagnesemia. The urinary calcium is the single discriminator, and choice D inverts it. The correct answer is C. Blood pressure is what separates this pair from the other cause of hypokalemic alkalosis and makes choices A and E identifiable as wrong. Both Bartter and Gitelman produce salt, wasting, so volume is low. Renin and aldosterone rise appropriately, and blood pressure stays normal or low. In Liddle syndrome and in primary hyperaldosteronism, the collecting duct retains sodium, so blood pressure is hitched and renin is suppressed, the opposite profile. Asking whether the patient is hypertensive sorts the entire group in one step. If you see hypokalemic alkalosis, leads to check the blood pressure first, then the urinary calcium. Which is the most likely diagnosis? A 46-year-old man has resistant hypertension and a potassium of 2.8 milliequivalents per liter. Plasma aldosterone is elevated, plasma renin activity is suppressed, and he has no edema despite sodium retention. Read the command, the most likely diagnosis. Aldosterone and renin move together in secondary causes and in opposite directions in primary disease. The aldosterone to renin relationship classifies the disorder. In primary hyperaldosteronism, Conn syndrome, from an adrenal adenoma or bilateral hyperplasia, aldosterone is produced autonomously, so sodium retention raises blood pressure and the resulting volume expansion suppresses renin. Aldosterone hitch with renin, Lao is the diagnostic signature. In secondary hyperaldosteronism, such as renal artery stenosis, renin drives the whole system and BOTH elevated, which excludes choice C. Addison disease is the mirror image, with aldosterone deficiency causing hyperkalemia and hypotension. The correct answer is B. The absence of edema is the detail that often confuses, and it has a name, aldosterone escape. Continued sodium retention expands volume enough to trigger atrial natriuretic peptide release and pressure natriuresis, which reestablishes sodium balance at a higher blood pressure. So these patients are hypertensive and hypokalemic, but not edematous. Choice D produces episodic hypertension with headache, palpitations, and sweating rather than persistent hypokalemia, and choice E raises cortisol with its own distinct phenotype. If you see hypertension with hypokalemia and suppressed renin, leads to think primary hyperaldosteronism. Which drug should each receive? A patient with recurrent calcium oxalate stones and mild hypertension needs a diuretic. A second patient has symptomatic hypercalcemia from malignancy and needs urgent calcium lowering. Read the command, which drug for each patient. The two diuretic classes move calcium in opposite directions, and each direction has its own indication. Loop diuretics inhibit the sodium-potassium 2-chloride cotransporter, abolishing the lumen-positive potential that drives paracellular calcium reabsorption in the thick ascending limb. So calcium is lost in the urine. That is exactly what is wanted in hypercalcemia, given alongside saline hydration. Thiazides enhance calcium reabsorption in the distal convoluted tubule, so calcium is retained and urinary calcium falls, which is precisely what a calcium stone former needs, while also treating the hypertension. Reversing the pair, as choice B does, would worsen both patients. The correct answer is A. The same pharmacology explains a benefit outside the kidney that appears in bone questions. Because thiazides retain calcium, they are associated with slightly higher bone density and fewer hip fractures, whereas loop diuretics promote calcium loss and may contribute to bone loss over time. Choice. E misplaces acetazolamide, which alkalinizes the urine and would actually promote calcium phosphate stone formation, making it a poor choice for a stone former. If you see a diuretic and calcium in the same question leads to loops, lose it. Thiazides, keep it. Which is the most likely diagnosis? A 61-year-old smoker has painless hematuria, a flank mass, and unexplained weight loss. Imaging shows a solid enhancing mass in the renal parenchyma, with tumor thrombus extending into the renal vein. Hemoglobin is elevated. Read the command, the most likely diagnosis. 2 renal malignancies present with painless hematuria, and where the tumor sits decides which one. Renal cell carcinoma arises from proximal tubular epithelium in the renal parenchyma, and its defining behavior is invasion of the renal vein with propagation toward the inferior vena cava. It is a classic producer of perineoplastic syndromes, erythropoietin causing polycythemia, parathyroid hormone-related peptide causing hypercalcemia, and renal causing hypertension. Transitional cell carcinoma arises instead from urothelium lining the renal pelvis, ureter, and bladder, so it presents as a filling defect in the collecting system rather than a parenchymal mass. Choice A wrong. The correct answer is D. The classic triad of flank pain, hematuria, and a palpable mass appears in only a minority of renal cell carcinomas, so the diagnosis is usually made incidentally or through a paraneoplastic clue, the elevated hemoglobin here being an unusual finding in a cancer patient and therefore a deliberate signal. Choice C occurs in young children and is associated with WT1 mutations, and choices B and E are benign lesions, the first containing fat and linked to tuberous sclerosis. If you see a parenchymal renal mass with renal vein invasion leads to think renal cell carcinoma. Which organism is responsible? A 39-year-old man who lived for years near the Nile has painless hematuria. Cystoscopy shows a bladder mass, and biopsy shows keratinizing CQ amala cell carcinoma. Urine microscopy earlier showed eggs with a terminal spine. Read the command. Which organism? 3 schistosome species differ by the organ they colonize and by the shape of the egg. Schistosoma haematobium inhabits the venous plexus of the bladder and its eggs, identified by a terminal spine lodged in the bladder wall, producing chronic inflammation, squamous metaplasia, and eventually squamous cell carcinoma. This matters because bladder cancer is otherwise transitional cell carcinoma in the overwhelming majority of cases. A squamous histology should immediately raise chronic irritation, whether from schistosomiasis or long-term catheterization. Schistosoma mansoni and japonicum instead inhabit mesenteric vessels, producing hepatic fibrosis and portal hypertension, and their eggs bear lateral spines. Choices A and B wrong. The correct answer is E. Squamous carcinoma of the bladder is worth holding as a small set of chronic irritation causes, because the exam uses histology as the clue: schistosomiasis, chronic indwelling catheters, and chronic stones. All schistosome species are treated with pyrizoquintel, and all require a freshwater snail intermediate host, which is why the geographic and exposure history carries diagnostic weight. Choices C and D affect the biliary tree and produce hydatid cysts respectively, neither involving the bladder. If you see squamous cell carcinoma of the bladder leads to think chronic irritation and ask about freshwater exposure. Which condition is present and what is its inheritance? A 42-year-old man has hypertension, flank pain, and hematuria. Ultrasound shows numerous bilateral renal cysts. His father required dialysis at 55. He also has mild headaches, and screening imaging reveals a small berry aneurysm. Read the command, the condition, and its inheritance. 2 polycystic diseases differ by age of onset, inheritance, and external associations. Autosomal dominant polycystic kidney disease presents in adulthood with progressively enlarging bilateral cysts, hypertension, flank pain, hematuria, and eventual renal failure. It is caused by mutations in PKD1 or PKD2, and the vertical transmission from an affected parent fits dominant inheritance. Its extrarenal associations are what make it dangerous beyond the kidney: berry aneurysms with risk of subarachnoid hemorrhage, hepatic cysts, mitral valve prolapse, and colonic diverticula. Autosomal recessive disease presents in infancy, often with the Potter sequence from oligohydramnios, and with congenital hepatic fibrosis. Choice A wrong. The correct answer is B. The berry aneurysm association is the reason the diagnosis carries urgency beyond renal monitoring, since subarachnoid hemorrhage can be the presenting and fatal event. Screening is considered when there is a family history of aneurysm. Choice C describes dilated collecting ducts causing recurrent stones and infection without progressive renal failure, and choice D would not produce hypertension and renal impairment in a man of this age with this family history. If you see adult bilateral renal cyst with a berry aneurysm, leads to think autosomal dominant polycystic kidney disease. Which combination of processes generates and maintains this gradient? In the renal medulla, the interstitial osmolality rises progressively from the corticomedullary junction to the papillary tip, reaching about 1200 milliosmoles per kilogram. Read the command, what generates and maintains the gradient? This is the machinery behind every concentrating and diluting question. The gradient is built by the undercurrent multiplier. The thick ascending limb actively pumps sodium, potassium, and chloride out of the tubule while remaining impermeable to water. That is the single energy consuming step, and it is why the ascending limb is called the diluting segment. The descending limb is permeable to water but not to salt, so water leaves passively and the tubular fluid concentrates. There is no active transport there, which excludes choices A and B. urea, recycling from the intermedullary collecting duct under antidiuretic hormone, contributes substantially to the deepest part of the gradient. The correct answer is E. Choice D inverts the role of the blood supply, which is the countercurrent E exchanger. The vasa recta run in hairpin loops and flow slowly, precisely, so that solute diffusing out of the ascending vessel re-enters the descending one, delivering oxygen without washing the gradient away. The practical consequence ties the physiology to pharmacology. Because loop diuretics block the very pump that builds the gradient, they abolish the kidney's ability both to concentrate and to dilute urine. If you see a concentrating ability question, leads to start at the thick ascending limb, which is the most likely mechanism of his acute kidney injury. A 24-year-old man is found after lying immobile for 12 hours following a seizure. Creatine kinase is 42,000 units per liter. Urine dipstick is strongly positive for blood, but microscopy shows no red blood cells. Potassium is 6.1 milliequivalents per liter, calcium is 6.8 milligrams per deciliter, and creatinine is 3.4 milligrams per deciliter. Read the command, the mechanism of the injury. The dipstick and the microscopy disagree, and that disagreement is the diagnosis. Prolonged immobility crushes and lyses skeletal muscle, releasing its contents. Myoglobin is filtered and is directly toxic to tubular epithelium, and it also precipitates within tubules, producing pigment-induced ocutubular necrosis. The dipstick detects heme, so it reacts to myoglobin exactly as it does to hemoglobin, giving a positive result for blood. Microscopy then finds no red cells, and that discrepancy is essentially diagnostic. The electrolytes confirm cell lysis, potassium and phosphate pour out of muscle, and the released phosphate binds calcium, producing hyperkalemia. The correct answer is D. Aggressive intravenous fluid resuscitation is the central treatment, aiming to maintain tubular flow and dilute the pigment before it precipitates, and it must begin early to preserve renal function. The hyperkalemia is the immediate threat to life and is managed on its own terms. One caution follows the calcium: hypocalcemia and rhabdomyolysis is usually not repleted unless symptomatic, because calcium released later during recovery can produce rebound hypercalcemia. Choice C describes tumor lysis syndrome, which shares hyperkalemia and hypocalcemia but follows chemotherapy rather than muscle injury. If you see a positive dipstick for blood with no red cells, leads to think myoglobin and check the creatine kinase. Which pairing is correct? Two patients develop kidney injury after coronary angiography. Patient 1's creatinine rises within 48 hours and returns to baseline by day 7 with a bland sediment. Patient 2's creatinine rises gradually over 3 weeks with livedo reticularis, lutose, eosinophilia, and low complement. Read the command. Which pairing is correct? 2 complications follow the same procedure, and the timing plus the skin separate them. Contrast. Induced nephropathy is an early transient injury. Creatinine rises within 24 to 48 hours through renal vasoconstriction and direct tubular toxicity, peaks around days 3 to 5, and resolves within a week or 2 with a bland sediment. Cholesterol. Embolization is a mechanical and inflammatory event. Catheter manipulation dislodges erythematous plaque, and crystals shower distally over WEX, producing progressive renal impairment with livedoretic, lutose with intact pulses, eosinophilia, and low complement. Reversing the two, as choice B does, contradicts both the timing and the skin findings. The correct answer is A. The preserved distal pulses in cholesterol embolization are worth emphasizing because they distinguish it from large vessel occlusion. The embolia are microscopic crystals lodging in arterioles, so the large arteries remain patent while the digits become ischemic. Prognosis differs accordingly. Contrast, nephropathy is usually self-limited and largely preventable with pure procedural hydration, whereas cholesterol embolization is often progressive and has no specific therapy. If you see, kidney injury after catheterization leads to let the interval and the skin decide which complication it is. Which sequence explains these findings? A patient with stage 4 chronic kidney disease has a calcium of 8.1 mg per deciliter, phosphate of 6.4 mg per deciliter, elevated parathyroid hormone, and low 1025 dihydroxyvitamin D. Bone biopsy shows increased osteoclastic activity. Read the command, sequence explaining the findings. The pattern of calcium, phosphate, and parathyroid hormone identifies which link in the chain failed. The failing kidney does 2 things at once. It cannot EXCR phosphate, so phosphate accumulates and binds calcium, lowering it, and it loses 1-alpha HY roxyl-ACE activity, so 25-hydroxyvitamin D is not converted to active calcitriol, and gut calcium absorption falls further. The parathyroid glands respond appropriately to that hypocalcemia by secreting more hormone, secondary hyperparathyroidism, and the sustained drive produces the osteoclastic bone disease of renal osteodystrophy. The defining pattern is LOW calcium with HIGH phosphate and HIGH parathyroid hormone. The correct answer is C. The 3 forms are distinguished entirely by that triad of values, which is why choice A is identifiable as primary disease. An autonomous adenoma raises calcium while lowering phosphate, the reverse of this patient. Tertiary hyperparathyroidism completes the set. After years of secondary stimulation, the glands become autonomous and calcium rises even though the original stimulus was hypocalcemia. Treatment addresses the drivers, dietary phosphate restriction with binders, and active vitamin D replacement. If you see, high parathyroid hormone leads to read the calcium and phosphate together before naming the type. Which enzymatic step is impaired? A patient with chronic kidney disease has normal 25-hydroxyvitamin D, but low 125 dihydroxyvitamin D. Supplementing with cholecalciferol raises the 25-hydroxy level without correcting the active hormone or the hypocalcemia. Read the command. Which enzymatic step is impaired? Vitamin D is activated in 2 organs, and the laboratory patent says which one has failed. Vitamin D activation proceeds in 3 locations. Skin converts 7-dehydrocholesterol to cholecalciferol under ultraviolet light. The liver performs 25-HY-hydroxyylation to produce the storage form measured clinically, and the kidney performs 1-alpha HY-hydroxyylation to produce calcitriol, the active hormone, under stimulation by parathyroid hormone and low phosphate. A normal 25-hydroxy level with a low 1025 level places the block squarely at the renal step, and the failure of supplementation to correct it confirms that the substrate was never the problem, which excludes choices A, B, and C. The correct answer is D. The therapeutic implication is direct and frequently tested. A patient with chronic kidney disease needs ACTIV, vitamin D, calcitriol, or an analog, because supplying more precursor cannot bypass a missing enzyme. The same enzyme explains an apparently unrelated disease. Activated macrophages in sarcoidosis and other granulomatous conditions express 1-alpha hydroxylase outside normal regulatory control, producing hypercalcemia with a suppressed parathyroid hormone. If you see low active vitamin D with normal storage form leads to think the kidney, and give calcitriol. Which process is present? A 68-year-old man with multiple myeloma develops nephrotic range proteinuria. Renal biopsy shows amorphous eosinophilic deposits in the mesangium that stain with Congo red and show APPL, green birefringence under polarized light. Read the command. Which process? One stain and one optical property make this diagnosis unambiguous. Congo red staining with APPL. Green birefringence under polarized light is the defining property of amyloid, and it reflects the beta-pleated sheet architecture common to every amyloid protein regardless of its origin. In multiple myeloma, the deposited protein is AL amyloid, derived from immunoglobulin light chains. In chronic inflammatory disease, it is AA amyloid derived from serum amyloid A. Deposition in the glomerulus produces nephrotic range proteinuria. Choice B produces nodules that are Congo red, negative, which is precisely why the stain is performed. The correct answer is A. Choice C is the important companion diagnosis in the same patient population and is separated by both site and urinalysis. Cas nephropathy deposits light chains in the tubulus, producing renal failure with relatively little albuminuria, and because the dipstick detects albumin rather than light chains, it can be misleadingly negative, which is why urine protein electrophoresis is required. Systemic amyloidosis adds features worth recognizing in a STEM: macroglossia, restrictive cardiomyopathy with low voltage ECG, hepatomegaly, and periorbital purpura. If you see Congo red positivity with apple green birefringence leads to think amyloid, then ask which protein. Which pairing is correct? Two young men have persistent microscopic hematuria. Patient 1 has normal hearing, normal vision, no proteinuria, stable renal function, and several similarly affected relatives with benign courses. Patient 2 has sensory neural hearing loss, lens abnormalities, proteinuria, and declining renal function. Read the command. Which pairing is correct? 2 inherited causes of isolated hematuria differ by what happens outside the kidney. Both conditions involve type 4 collagen of the basement membrane, but with very different consequences. Thin basement membrane disease, benign familial hematuria, causes uniformly thin membranes, isolated microscopic hematuria, and a benign course with normal renal function and no external features. Beauport syndrome, usually X-linked, involves a more severe defect in the alpha-5 chain, producing basement membrane splitting with a basket weave appearance, progressive renal failure, sensory neural hearing loss, and lens abnormalities such as anterior lenticonus. The external findings assign the diagnosis, and choice D inverts them. The correct answer is E. The mnemonic for output cannot see, cannot hear, cannot pee captures the triad efficiently, and the X-linked inheritance explains why affected males are more severely involved than carrier females. Choice B deserves a moment because IgA nephropathy also causes recurrent hematuria in young men, but it does so in episodes following mucosal infections rather than persistently, and it lacks the family pattern of benign disease described in patient 1. If you see familial hematuria leads to the presence or absence of deafness, decides between the two. Which pairing is correct? 2 patients have a normal anion gap metabolic acidosis. Patient 1's urinary anion gap is negative at -28. Patient 2's urinary anion gap is positive at +22. Read the command. Which pairing is correct? 2 causes of normal gap acidosis and 1 bedside calculation separates them. The urinary anion gap is urinary sodium plus potassium minus chloride, and it works as an indirect measure of ammonium excretion, ammonium being unmeasured but accompanied by chloride. A healthy kidney facing acidemia excretes large amounts of ammonium chloride, so urinary chloride exceeds the measured cations and the gap becomes negative. That is the appropriate response, and it points to an external cause of the acidosis, namely gastrointestinal bicarbonate loss from diarrhea. A positive gap means ammonium excretion has failed, indicating renal tubular acidosis, so choice A inverts the rule. The correct answer is B. Keeping the two anion gaps distinct is essential because they answer different questions and are calculated from different fluids. The serum anion gap asks whether unmeasured ACIZ has been added, separating gap from non-gap acidosis. The urinary anion gap asks whether the kidney is responding appropriately, separating renal from gastrointestinal causes within the non-gap group. Choice E understates a calculation that is both simple and decisive at the bedside. If you see a normal gap acidosis leads to calculate the urinary anion gap and ask whether the kidney is working. Which statement about this alkalosis is correct? A patient with persistent vomiting from pyloric obstruction has a pH of 7.52, bicarbonate of 38 milliequivalents per liter, and chloride of 88 milliequivalents per liter. Urine chloride is 8 milliequivalents per liter. Read the command. Which statement about the alkalosis is correct? Metabolic alkalosis splits into two treatable groups, and urine chloride is what assigns the group. Vomiting loses hydrochloric acid, generating alkalosis, and loses volume, which the kidney defends by reabsorbing sodium avidly, and it drags bicarbonate along, so the alkalosis is maintained as long as the patient is volume depleted. A urine chloride below 20 signals exactly that state, and it makes the alkalosis CHL-oride responsive. Restoring volume with normal saline supplies chloride allows bicarbonate to be excreted and corrects the disturbance. Urine sodium is unreliable here because bicarbonaturia obligates sodium loss, which is why chloride rather than sodium is measured. The correct answer is C. Choice B inverts the interpretation in an instructive way, because primary hyperaldosteronism is the classic CHL-oride resistant cause. Those patients are volume. expanded rather than depleted, so urine chloride is H, and giving saline would worsen their hypertension without correcting the alkalosis. Vomiting also explains the accompanying hypokalemia through two routes at once: direct gastric loss and aldosterone-driven renal wasting as volume falls. If you see a metabolic alkalosis leads to measure urine chloride, not urine sodium. Which statement best explains the difference in pH? A patient with severe COPD has a pH of 734, PaCO2 of 68 millimeters of mercury, and bicarbonate of 36 milliequivalents per liter. A second patient with an acute asthma exacerbation and fatigue has a pH of 721, PaCO2 of 66 millimeters of mercury, and bicarbonate of 26 milliequivalents per liter. Read the command. What explains the pH difference? Two patients have nearly identical carbon dioxide levels and very different pH values because compensation takes time. Renal compensation for respiratory acidosis is slow. Acetylene, bicarbonate rises only about 1 milliequivalents per liter for every 10 millimeters of mercury rise in PaCO2 through tissue buffering alone. So the second patient's bicarbonate of 26 is exactly what an acute rise predicts, and the pH falls steeply. Chronically, over 3 to 5 days, the kidney retains bicarbonate, raising it about 4 milliequivalents per liter per 10 millimeters of mercury. So the first patient's bicarbonate of 36 reflects weeks of adaptation, and the pH is nearly normal despite a PaCO2 of 68. Same carbon dioxide, different duration, different pH. The correct answer is B. Choice C would require the bicarbonate to exceed what chronic compensation predicts, which it does not. The value of 36 is precisely what is expected, so no second primary disorder exists. Recognizing the difference matters clinically because it changes the target. The chronically compensated patient must not be ventilated down to a normal PaCO2, since doing so would unmask the retained bicarbonate and produce a severe metabolic alkalosis. Their own baseline is the goal. If you see a high PaCO2 leads to, let the bicarbonate tell you whether it is acute or chronic. Which explanations apply? Glucose appears in the urine when the plasma concentration exceeds roughly 200 milligrams per deciliter, even though all filtered glucose is normally reabsorbed. A second patient has glycosuria at a plasma glucose of 110 milligrams per deciliter while taking a new diabetes medication. Read the command. Which explanations apply? Glycosuria has two very different causes, and one of them is now deliberately induced by a drug class. Filtered glucose is reabsorbed in the proximal tubule by sodium glucose cotransporters, principally SGLT2. Because carrier numbers are finite, reabsorption has a transport maxima below a plasma threshold near 200 milligrams per deciliter. All glucose is recovered, and above it, the excess spills into the urine. That is the first patient. The second is glycosuric at a normal plasma glucose because the transporter itself has been pharmacologically BLOC'd, an SGLT2 I inhibitor, which lowers glucose precisely by lowering the renal threshold. Choice. A cannot apply to a plasma glucose of 1 on 10, which is far below any normal threshold. The correct answer is D. The adverse effects follow directly from the mechanism and are commonly tested. Persistent glycosuria promotes genital mycotic infections and urinary tract infection, and the accompanying osmotic diuresis lowers blood pressure and volume. The most distinctive complication is EUG lysis, nic-diabetic ketoacidosis, ketoacidosis with a deceptively normal or only mildly elevated glucose, which is easily missed unless ketones are checked deliberately. If you see glycosuria with a normal plasma glucose leads to think a blocked transporter, not a high load, which is the primary mechanism of this anemia. A patient with stage 5 chronic kidney disease has a hemoglobin of 8.2 grams per deciliter. Ferritin and transferrin saturation are normal, mean corpuscular volume is normal, and reticulocyte count is inappropriately low. Read the command, the primary mechanism. Anemia in kidney disease has several contributors, and the indices point to which one dominates. The peritubular interstitial cells of the kidney sense oxygen delivery and produce erythropoietin. As functioning renal mass is lost, that production falls, and the marrow, otherwise healthy, is simply not being told to make red cells. The result is a normocytic, normochromic anemia with a low reticulocyte count, exactly as described, and with normal iron studies. Choice B would produce a microcytic anemia with low ferritin and low saturation, and choice C would produce a macrocytic anemia. The normal indices exclude both. The correct answer is A. 2 practical points govern treatment and are examinable. Iron stores must be adequate. Before an erythropoiesis, stimulating agent is given because stimulating a marrow without substrate is ineffective, and functional iron deficiency develops rapidly once erythropoiesis accelerates. And the hemoglobin target is deliberately SU normal, since trials correcting to normal values showed increased stroke, thrombosis, and mortality. Choice D would raise the reticulocyte count rather than lower it. If you see normocytic anemia with low reticulocytes in kidney disease leads to think erythropoietin deficiency. Which is the most likely diagnosis? A 26-year-old woman has dysuria, frequency, and suprapubic discomfort for 2 days. She is a febrile with no flank pain and no costovertebral angle tenderness. Urinalysis shows puria and positive nitrites. Rate the command. The most likely diagnosis: lower and upper urinary tract infection share the urinalysis. The systemic features separate them. Acute CY status is confined to the bladder, so symptoms are local, dysuria, frequency, urgency, and suprapubic discomfort without fever or systemic upset. Acute PY lone FRITIS involves the renal parenchyma, so it adds fever, chills, a flank pain, and costovertebral angle. Tenderness is, and its urinalysis characteristically shows white CL casts, which arise only in the kidney. Their absence, together with the afebrile state, places this infection in the bladder and excludes choice. A. Positive nitrites indicate a nitrate-reducing organism, most often Escherichia coli. The correct answer is C. Choice B is the important alternative when the urine culture is negative. Chlamydial urethritis produces dysuria with sterile, pyuria, white cells without bacterial growth and typically without nitrites, and is treated quite differently with attention to partners. Sterile pyuria has a small differential worth carrying, including chlamydia, tuberculosis, and interstitial nephritis. Choice D is a chronic pain syndrome without infection, and choice E would present with colicky flank pain radiating to the groin. If you see dysuria without fever or flank tenderness, leads to think cystitis and reserve cast for the kidney. Which mechanism explains the cough and its resolution? A 64-year-old man with hypertension is started on lisinopril. 2 weeks later, he develops a persistent dry cough. He is switched to losartan and the cough resolves. Read the command, the mechanism of the cough, and why switching resolved it. The difference between the two drug classes is not the receptor, but the enzyme. Angiotensin converting enzyme performs two jobs. It converts angiotensin E to angiotensin II, and it degrades bradykinin. Inhibiting it therefore lowers angiotensin II, the therapeutic effect, while simultaneously allowing bradykinin and substance P to accumulate, and that accumulation irritates airway sensory nerves, producing the characteristic dry cough. Angiotensin receptor blockers act at the receptor rather than the enzyme, leaving bradykinin degradation intact, which is exactly why switching resolved the symptom and why choice B is the reverse of the mechanism. The correct answer is E. The more dangerous manifestation of the same mechanism is angioedema, which can obstruct the airway and requires immediate discontinuation. It is more frequent in patients of African descent and can appear months or years after starting the drug. What the two classes share is equally testable. Both cause hyperkalemia by reducing aldosterone, both are contraindicated in pregnancy for fetal renal maldevelopment, and both can precipitate acute kidney injury and bilateral renal artery stenosis. If you see cough or angioedema on an antihypertensive leads to think bradykinin and switch to an ARB. Which mechanism mediates this response? In a healthy kidney, an increase in sodium chloride delivery to the macula densa produces a fall in glomerular filtration rate in that same nephron. Read the command, the mechanism. This is the nephron's own thermostat, and it explains how each glomerulus regulates itself. The macula densa is a specialized plaque of cells in the distal tubule sitting against its own glomerulus. When it senses Higgs sodium chloride delivery, meaning that nephron is filtering more than it can reabsorb, it releases adenosine, which constricts the efferent arteriole and lowers filtration in that single nephron. This is tube-U-log glomerular feedback, a negative loop protecting the tubule from being overwhelmed. The opposite signal, low sodium chloride delivery, triggers renin release from the juxtaglomerular cells and prostaglandin-mediated afferent dilation to restore filtration. The correct answer is A. Choices. B and C describe the opposite arm of the same system, which is why they are plausible, but directionally wrong here. Renin and prostaglandin release are the response to LOW delivery, not high. The system also explains a drug effect worth connecting. Loop diuretics block the sodium-potassium 2-chloride cotransporter in the macula densa itself, so the sensor perceives falsely LOW delivery and renin release rises, contributing to the reactive activation seen with chronic loop diuretic therapy. Which is the most likely diagnosis, and what prophylaxis was indicated. A 58-year-old man begins chemotherapy for a bulky lymphoma. 2 days later, he has oliguria with potassium 6.4 milliequivalents per liter, phosphate 8.1 milligrams per deciliter, uric acid 14 milligrams per deciliter, calcium 6.9 milligrams per deciliter, and creatinine 3.6 milligrams per deciliter. Read the command, the diagnosis, and the prophylaxis. The electrolyte pattern is the fingerprint of massive cell destruction. Rapid lysis of a large tumor burden dumps intracellular contents into the circulation. Potassium and PHOSPD pour out, nucleic acids are catabolized to uric ACACE, and the released phosphate binds calcium, producing hypocalcemia. Uric acid and calcium phosphate then crystallize within the tubules, causing acute kidney injury. This tetrad, high potassium, high phosphate, high uric acid, low calcium, is unique to tumor lysis syndrome and appears within 1 to 3 days of treating a bulky chemosensitive malignancy such as high-grade lymphoma or acute leukemia. The correct answer is C. The distinction between the two urate-lowering drugs is clinically meaningful and testable. Allopurinol inhibits xanthine oxidase and therefore prevents further urate formation but does nothing to urate already present, whereas rasburicase is a recombinant urate oxidase that degrades existing urate and is used when the burden is high or established. Rasburicase causes hemolysis in G6PD deficiency and must be avoided there. Choice D shares hyperkalemia and hypokalemia but would show a very high creatine kinase after muscle injury. If you see hyperkalemia with hyperuricemia and hypocalcemia after chemotherapy leads to think tumor lysis. Which consequence follows in these tissues? A patient with poorly controlled diabetes develops painful peripheral neuropathy and early cataract. Aldose reductase activity in these tissues converts glucose to sorbitol, but sorbitol dehydrogenase is absent. Read the command, the consequence in these tissues. One enzyme is present and the next is missing, and everything follows from where the pathway stops. The polyol pathway converts glucose to sorbitol via aldose reductase, and then sorbitol to fructose via sorbitol dehydrogenase. Tissues that possess the first enzyme but lack the second, the lens, retina, Ch1 cells, and kidney, cannot complete the conversion. Sorbitol is a polar molecule that crosses membranes poorly, so it becomes trapped intracellularly, draws water osmotically, and injures the cell. That mechanism links chronic hyperglycemia to cataract, retinopathy, and peripheral neuropathy, and choices A and C describe an escape route these tissues do not have. The correct answer is D. The same logic explains a separate inherited disease and is worth pairing. In galactokinase deficiency, galactose is reduced by the same aldose reductase to galactidol, which is likewise trapped in the lens and causes infantile cataracts. Recognizing the shared mechanism turns two unrelated-looking facts into one principle. A metabolite with no downstream enzyme and no way out accumulates and damages by osmosis. If you see a metabolite trap for lack of the next enzyme, leads to think osmotic injury in lens, nerve, and kidney. Which zone of the prostate is most likely involved? A 70-year-old man has progressive difficulty starting his urinary stream, a weak flow, and nocturia. Digital rectal examination reveals a smoothly enlarged, non-tender prostate. Prostate-specific antigen is mildly elevated at 5-2 nanograms per milliliter. Read the command, which zone? Benign hyperplasia and carcinoma arise in different parts of the prostate, and that anatomy explains their different presentations. Benign prostatic hyperplasia arises in the transition zone, which surrounds the urethra, so even modest enlargement compresses the urethral lumen and produces the obstructive symptoms of hesitancy, weak stream, and nocturia early in the disease. Prostate carcinoma arises in the peripheral zone, away from the urethra and adjacent to the rectum, so it is palpable as a hard nodule on rectal examination, but causes obstruction only late, which is why it is often asymptomatic when curable. The smooth, non-tender enlargement described fits hyperplasia, excluding choice A. The correct answer is B. The therapeutic pairing follows the pathology and is examined regularly, alpha 1. Blockers such as tamsulosin relax prostatic and bladder neck smooth muscle and relieve symptoms within days, while 5-alpha reductase. Inhibitors such as finasteride block conversion of testosterone to dihydrotestosterone and shrink the gland over months. Prostate-specific antigen is raised by both hyperplasia and cancer, which is why a mild elevation is not diagnostic, and finasteride roughly halves the measured value, a correction that must be remembered when interpreting it. If you see obstructive urinary symptoms with a smooth prostate leads to think transition zone hyperplasia. Which renal response restores balance, and by what mechanism? A patient's plasma osmolality falls below 275 milliosmoles per kilogram after drinking a large volume of water. Read the command, the response, and its mechanism. Water balance and sodium balance are controlled by different hormones, and mixing them is the standard error. Osmolality is regulated by water handling, and water handling is controlled by antidiuretic hormone. Hypothalamic osmoreceptors detect the fall in osmolality and suppress antidiuretic hormone release. Without it, aquaporin 2 channels are withdrawn from the collecting duct membrane. The duct becomes impermeable to water, and a large volume of dilute urine is excreted until osmolality returns to normal. Choice A describes the response to a HIH osmolality, exactly reversed. The correct answer is C. Keeping the two axes separate resolves most electrolyte questions, and choice B belongs to the other axis. Aldosterone regulates sodium and therefore extracellular volume, not osmolality. One override is worth knowing because it explains hyponatremia in hypovolemic states. When volume depletion becomes severe, baroreceptor-driven antidiuretic hormone release overrides the osmotic signal, so the body retains water and dilutes the plasma, sacrificing tonicity to defend perfusion. If you see an osmolality question leads to reach for antidiuretic hormone, not aldosterone, which intervention is now indicated? A patient with end-stage renal disease has refractory hyperkalemia at 7-8 milliequivalents per liter, a pH of 711, pulmonary edema unresponsive to diuretics, and a pericardial friction rub with confusion. Read the command. Which intervention? Several indications for dialysis are present simultaneously, and recognizing the set is the point. The classic indications for urgent dialysis are remembered as AEIOU, severe acidosis, E. electrolyte I disturbance, chiefly refractory hyperkalemia, I. intoxication with a dialysable poison, fluid overload unresponsive to diuretics, and uremia with its complications, notably pericarditis and encephalopathy. This patient meets at least 4 of the 5. Once the kidney has failed to the point of uremic pericarditis and refractory overload, pharmacologic measures cannot substitute for solute and fluid removal, so choices A, B, C, and D delay definitive treatment. The correct answer is E. Uremic pericarditis deserves particular emphasis because it is an absolute indication that does not wait for a laboratory threshold, and it carries a risk of hemorrhagic effusion and tamponade. Note also which poisons are dialysable. Since it appears in toxicology stems, methanol, ethylene glycol, salicylate, and lithium are removed effectively, whereas highly protein-bound or large volume of distribution drugs such as tricyclic antidepressants are not. If you see uremic pericarditis or refractory overload leads to dialyze rather than escalate drugs. Which is the most likely diagnosis? A 58-year-old woman is found to have a serum calcium of 11.6 milligrams per deciliter on routine testing. Phosphate is low, parathyroid hormone is elevated, and urinary calcium is high. She has a history of a kidney stone. Read the command. The most likely diagnosis. Hypercalcemia divides first by whether parathyroid hormone is high or suppressed, then by urinary calcium. An elevated parathyroid hormone in the face of hypercalcemia is inappropriate and indicates autonomous secretion. Primary. Hyperparathyroidism, usually from a single adenoma. The hormone raises calcium and lowers phosphate by promoting phosphaturia, and the filtered calcium load produces hypercalciuria with stones. The classic summary is stones, bones, groans, and psychiatric overtones, though most cases today are detected incidentally. All PTH iron-dependent causes, malignancy, vitamin D excess, granulomatous disease, suppressed parathyroid hormone, which excludes choices A, D, and E in one step. The correct answer is B. Choice C is the one genuine competitor, and the reason urinary calcium is measured, familial hypocalcium, is LOW. Hypercalcemia also shows mildly elevated calcium with an inappropriately normal or high parathyroid hormone, but a defective calcium sensing receptor makes the kidney reabsorb calcium avidly, so urinary calcium is LOW. The distinction is surgical. That condition is benign and requires no parathyroidectomy, whereas operating on it would not correct the calcium. If you see hypercalcemia with a high parathyroid hormone leads to check the urinary calcium before considering surgery. 12-year-old boy has hematuria, oliguria, and hypertension 4 weeks after impetigo. C3 is low and anti-streptolysin O is elevated. Electron microscopy of a biopsy would be expected to show which finding. Read the command, the expected electron microscopy finding. Each glomerulonephritis has a deposit in a characteristic location. Post-streptococcal glomerulonephritis follows a streptococcal skin or throat infection by 1 to 3 weeks, impetigo being a classic skin source, and consumes complement, so C3 is LOW. Preformed immune complexes deposit on the OUT, e.g., subepithelial side of the glomerular basement membrane, producing the dome-shaped subepithelial hump seen on electron microscopy, with granular lumpy bumpy IgG and C3 on immunofluorescence. Choice C describes anti-GBM disease, and choice D, minimal change disease, neither produces a nephritic picture with low complement. The correct answer is A. Building a small map of deposit locations answers a whole family of questions efficiently, since choice B belongs to membranal proliferative disease. Subepithelial humps mean post-streptococcal, subepithelial, spiken. Dome means membranous. Subendothelial deposits with tram-track double contours mean membranal proliferative, and mesangial IgA means IgA nephropathy. Note also which serology to request after a skin infection. Antigenase B is more reliable than anti-streptolysin O following impetigo. If you see nephritic syndrome with low C3 after a streptococcal infection leads to expect subepithelial humps, which is the most likely cause. A 34-year-old woman has resistant hypertension and an abdominal bruit. Imaging shows a right renal artery with alternating stenosis and dilations, giving a string of beads appearance. There is no atherosclerotic calcification, and she has never smoked. Read the command, the most likely cause. Two diseases narrow the renal artery, and the patient's age and the shape of the lesion separate them. Fibrom. Muscular dysplasia is a non-inflammatory, non-atherosclerotic disease of the arterial media occurring predominantly in young women. Alternating areas of fibrous thickening and thinning produce the characteristic string of beads appearance, typically in the distal 2/3 of the renal artery. The atherosclerotic renal artery stenosis is the other major cause, but occurs in older patients with vascular risk factors, involves the proximal artery near the ostium, and shows calcification, none of which fits here, excluding choice A. The correct answer is E. The physiology explains the hypertension and links back to an earlier trap. Stenosis reduces perfusion pressure at the juxtaglomerular apparatus. Renin rises, and angiotensin II drives systemic hypertension while maintaining glomerular filtration through efferent constriction. That dependence is why an ACEase inhibitor can precipitate acute kidney injury in bilateral disease. Choices B and C are inflammatory vasculitides with systemic features and raised inflammatory markers, and neither produces the string of beads morphology. If you see a string of beads in the renal artery of a young woman leads to think fibromuscular dysplasia. Which structure was most likely injured, and what is its anatomic relationship? During a hysterectomy, the surgeon ligates the uterine artery near the lateral fornix. Postoperatively, the patient develops unilateral hydronephrosis. Read the command, the structure injured and its relationship. One anatomic phrase covers this, and it is worth carrying verbatim. The uret passes beneath the uterine artery, approximately 2 centimeters lateral to the cervix, a relationship captured by the phrase water, under the bridge, water being the ureter, and the bridge, the uterine artery. Because the two structures cross at that point, Ligating or clamping the uterine artery during hysterectomy risks, including the ureter, and obstruction produces postoperative HY drawn frosis with flank pain and a rising creatinine. This is the single most commonly tested surgical relationship in pelvic anatomy. The correct answer is D. The male equivalent is worth attaching, since the same relationship is examined from the other side. The ureter passes uender, the ductus deferens, and the three anatomic narrowings of the ureter, the pelvic-ureter junction, the crossing of the pelvic rim, and the vesico-ureter junction are exactly where stones lodge, which is why they appear in college questions. Choices A, B, and C misstate relationships that would not produce ureteric obstruction. If you see hydronephrosis after pelvic surgery leads to think water under the bridge. 50 questions done. 5 discriminators worth carrying out of this session. Every one of those separated two conditions that shared a presentation and differed by a single measurement. That is the habit this series builds. Next in the series, microbiology and immunology. Step logic. Learn how to think, not memorize.